Welcome to ASA Central Line, the official podcast series of the American Society of Anesthesiologists, edited by Dr. Adam Stryker.
Welcome to Central Line. I'm your editor and host, Dr. Adam Stryker. Today, we have a special treat for you. I am joined by Dr. Edward Mariano, co-chair of ASA's Acute Pain Taskforce, someone who I've wanted to have on this podcast for some time, and I am really looking forward to talking with him. So many topics Dr. Mariano could discuss. Unfortunately, we have to limit it to one topic today, but today he's going to tell us a little bit about ASA's new guidelines on the topic of acute pain. And I'm looking forward to learning more about that, as well as I'm sure our listeners are looking forward to it too. And I'm sure they will value the information that he can provide. So Dr. Mariano, welcome to the show.
Yeah, thank you so much, Adam. I really appreciate being on here. And I honestly, I can't believe that we haven't had a chance to get together like this before. I really appreciate the work you do on behalf of ASA and just what a great communications channel for all of our members.
Well, thank you so much. It's a shame that we have not had the chance to talk sooner on the podcast, but you're here now and I'm thrilled. It's a great segue because this is your first time on Central Line. And oftentimes we have our guests that haven't been on before tell our listeners a little bit about their background and their current role. So if you don't mind, give our listeners just a little bit of information about yourself.
Thanks for the opportunity, and no problem at all not having me on up until this point, because to be honest, I've really enjoyed listening to all of these other fantastic leaders and members throughout our society and just hearing all of the great things that they do. And I honestly don't like listening to myself. So, and not having me on the podcast has been great because then I get to listen to you and all the others instead. So I have a few roles right now within ASA. I'm very fortunate to have been asked to participate in various ways, just to serve our society and our specialty. And currently, I'm the ASA Section Chair for Education and Research, which is my science academic hat. But I also represent our ASA as the current Procedural Terminology Advisor, which sits under professional affairs and is definitely one of my big passions these days, especially with the economics of healthcare and anesthesiology. In the recent past, I've chaired the Committee on Regional Anesthesia and Acute Pain Medicine, which is very relevant to our guidelines. And I'm currently co-chairing our task force for this new version of the acute pain medicine guidelines, which is actually very relevant to two big projects that I helped co-chair for ASA in the last few years, which is our pain summits, which really brought together with ASA's leadership, so many of our surgical societies, as well as the AMA and the American Hospital Association. So those have all been, I think, really important projects that ASA has really led the way on. And it's been fantastic to not only be part of those, but also to try to help share that awareness with so many of our members and non-members.
Yeah, it's wonderful. And such a prescient topic, given that the anesthesiologist's involvement in all sorts of facets of medical care outside the operating room. And it's something we've always done, managing acute pain. Talk a little bit about why the guidelines now, or what specifically about the guidelines are prescient for the current state of affairs at this time.
Yeah, I mean, I think that in terms of timing, when I look back to see when the last time ASA issued an acute pain management practice guideline, it was a while ago. It was in 2012. And it doesn't mean that ASA hasn't been working on this in the meantime. It's just, as you're well aware, there's just been so many different joint efforts on the practice of not just perioperative pain management, but also opioid stewardship. And I think ASA has been a real leader in trying to raise awareness about the judicious use of opioids, the appropriate use of opioids. Obviously, we can't be anti-opioid because it is an important class of analgesics, but really just trying to guide evidence-based recommendations on how to best care for patients while not increasing their perioperative risk. And so I really feel like this current version of our acute pain management guidelines, with a focus on regional analgesia, I think it's a real natural expansion of recent work. I mentioned the pain summits, which ASA led the way on. And those two pain summits brought together first 13 societies, and then the second one is 14 societies, really working on what we consider just the basis, the foundation for what good perioperative pain management is. And that's important because I think that this concept of multimodal analgesia or multimodal pain management, using multiple therapies that really work on different parts of the pain pathway, it is one of our 7 principles of perioperative pain management. So I think it's become at least common in our discussions about what basic pain management looks like. And it's really allowed us then with this guideline and the second part to really just focus on the contribution of regional analgesia, because I don't think we would have any debate about whether or not giving patients routine acetaminophen, if it's not contraindicated, is worthy of debate. And I don't think we would disagree that using appropriate evidence-based therapies, opioid or non-opioid, systemically is really up for debate either. So what we tried to do with this one is really to focus on what is the additional contribution of regional analgesics to good perioperative pain management. And that's actually an important perspective to have, especially when we're talking with not just our anesthesiology colleagues, but surgical colleagues and also our practice and hospital administrators.
You mentioned regional analgesia, and the guidelines are obviously geared towards any anesthesiologist who wants to engage in implementing that as part of their overall pain regimen. I mean, this is right up your alley with regional analgesia and regional anesthesia. And I do want to deviate just a little bit to talk about that for a second. What is your overall take on how much regional anesthesia and or analgesia is implemented in the general routine care of anesthetic patients? And I guess the corollary would be, could it be more? And what are the hurdles or the limitations for why we don't utilize it as much as we should, if that is indeed the case?
Yeah, I think this is probably one of the big sets of questions that I think has been driving this current phase in my career. And when we were in training, regional anesthesia and analgesia really weren't considered a subspecialty area. I mean, even when I think about my current career and the idea, if you asked me 25 years ago, could you see yourself as a regional anesthesiologist? I would have asked you, well, what's that? How did someone in anesthesiology just do that thing? Because it was always part of general anesthesia care, because it's one of these incredibly visible parts of anesthesiology, because the idea that you can target a part of the body and provide an anesthetic and then to transform that into a targeted analgesic is such an incredible tool and an incredible therapy we can offer patients. But to your question, I mean, I think that right now, even though regional anesthesia and analgesia is considered a subspecialty area, and we have nationally accredited fellowship programs just in that one subspecialty, overall, it's still unfortunately underutilized. And it's for many reasons. I think we now have widely adopted ultrasound. I mean, it's now considered standard practice to use ultrasound or peripheral and fascial plane blocks. But because of that, we've also seen an explosion in the number of procedures. And back in the day before ultrasound, I mean, there were really a handful of regional block procedures that you could know and practice as an anesthesiologist and just get really good at them. And in some ways, just the explosion of techniques, it gives you the luxury of choice, but can also be incredibly intimidating. And I think that there has been a challenge in some ways of getting anesthesiologists in practice to adopt some of these new techniques, because which ones should you learn? What do you do when before, when we had like 6 blocks and now we have 1,000 blocks? I mean, it's really tough to really focus on what you need to know. And so I do think that that's had the unfortunate and somewhat unpredicted or not well predicted effect of actually not expanding access to regional anesthesia, which I don't think was anyone's intent. I mean, I love innovation. My regional anesthesia colleagues are incredibly enthusiastic and always trying to find new ways to try to spread the access of regional anesthesia to more and more people. But I think that having a core set of blocks that all anesthesiologists can know, at least in our regional anesthesia educational community, we kind of refer to them as the Plan A blocks. So going back to being an anesthesiologist, you always have to have like a good plan A and then a plan B and C and D. Every anesthesiologist should have their go-to blocks, their plan A, and that they can do on a regular basis for those patients who are having surgeries of high volume where we know that they're going to make a big difference. And so I think we've come back to that a bit, going back to the general anesthesia practice as being really based on incorporating some of these foundational regional anesthesia techniques. And we know that naturally regional anesthesia is procedure specific. And we need to go back to thinking about how we teach and practice regional anesthesia with really a focus on specific procedures, but also I think now trying to incorporate some of the person-specific pain management as well.
Right, of course. Well, let's go back to the acute pain recommendations. Share a little bit about the insights into garnering the data, as well as maybe a little bit of the highlights of what the recommendations are, or the highlights of the entire set of recommendations that you'd like our listeners to get a sense of.
Well, sure. Yeah, thank you for the opportunity, by the way, just to share this, just because I think it's such an important document and we need to get the word out that it's even available. And I will say, and just from the perspective of someone who's worked on guidelines, and yeah, obviously I have a great insight into how this one was made in particular, but I think it's also important as a reader of guidelines, pay close attention to when societies issue evidence-based guidelines, because I think that those are the documents that we in general try to look to for reasons to change practice. And no guidelines, and I think this is true of this one as well as all the other ones within ASA or from other societies, is that we have to remember that guidelines are never carved in stone. So they're not meant to be recommendations that will necessarily last forever because they're very dependent on the evidence. So when I talk about this particular guideline, I think it's really important to know the context. And they're intimidating documents to read because the methods section is really long, because we try to be very transparent in the way that guidelines are performed. Because if any reader, looks at this document and maybe doesn't agree, or maybe wants to compare it to other guidelines that are issued by other societies, you have to make sure you're comparing apples and apples. And so I think that knowing the methods is key. We try to provide as a group within practice parameters. We try to provide all the supplemental information as well. Yeah, just so that way anyone who really wants to get into the weeds and figure out like, how did you come up with that evidence basis and how did you base your recommendations on them, can all figure out how that was done. So for this guideline, I think the time frame is important. What we didn't want to do was go back in the history of time and back to the origin of surgery and regional anesthesia and start from there, because that obviously would have given us a probably much larger volume of studies to go through, but they also would not have necessarily been very relevant to current practice because, as I mentioned, we've all seen the work performed in enhanced recovery and multimodal analgesia. ASA led the pain summits, and that really has helped influence modern practice. So we wanted to focus on the time frame from the last ASA practice guideline for acute pain. So that was published in 2012. So it makes sense that the literature search for the present guideline started at the beginning of 2013. And I'll go through a little bit about the process, but because ASA guidelines, not only are they documents that are generated from the research team, they also have to go through the ASA Board of Directors and the House of Delegates. So that process does add a few extra steps and some additional time because ASA guidelines, they reflect the society. So they have to go through a number of other review periods, in which I think is much, much more rigorous than your typical manuscript that gets submitted for peer review. But because of that, the end time for the search may be shorter than people expect, because this guideline was published online just in December and was published in an issue in January, just this past month. But the end result for the search was actually mid-2023, and then was updated again before the final version was sent to the board. So that was updated in December of 2024. But when you're thinking back and you're looking at the articles that are included versus not included, the reason why the search ended now more than a year ago is actually because of that timeline where the guidelines have to be approved by the board and house. In addition to that, we have our own task force members who include a number of regional anesthesia experts also contributed their own references. And we looked at other published systematic reviews and other manuscripts for other references. We looked at trial registries to see if are there any papers that perhaps were studied, maybe they weren't reported. We want to make sure we account for publication bias. And we only included randomized clinical trials because we know from the level of evidence, we want to do a systematic review of RCTs, which would then put that at the highest level of evidence to back up the guideline. And unfortunately, one of the challenges with systematic reviews and meta-analyses is that you're very limited. Your analysis is limited to the measures that are collected by the original studies. So we can't go back and change the outcomes that the study investigators chose to pursue, but we can only design our systematic review and meta-analysis around the outcomes that are available. So while we're all very interested in clinical medicine and in clinical research in terms of many patient-oriented outcomes and patient-reported outcomes. They're not always reported routinely in many of our research studies. So we focused at least our critical outcomes, what we consider the primary outcome, really to be pain scores and opioid use in 24 hours, because those are the ones that are repeatedly reported in RCTs. We did collect data on other outcomes that we thought were important, like for studies that did collect pain at 3 months after surgery, or studies that collected quality of recovery and block-related complications, functional outcomes, and patient satisfaction. All of those we consider extremely important, and we wanted to report them as much as the evidence would allow, but we couldn't design the meta-analysis based on those other outcomes just because they're not routinely reported, unfortunately. And that is something that we did mention in discussion of the guideline, because those are critical outcomes that future research studies really need to use. But I'll jump in. I'll give you just a kind of a high-level overview of what the recommendations are. Thankfully, the paper itself, while it is lengthy, there is a very nice summary table for all of the recommendations. And I do recommend that for any of our listeners who are interested in reviewing the guideline, that they look at the table, but then they also look at the discussion points for each of the different recommendations, just so that way they have a pretty good background and understanding of how that discussion that led to the recommendation came about. For some things, when we look at evidence, we look at risk of bias, we look at the strength of evidence using the grade recommendations. So there are certain rules, like, for example, if the level of evidence peaks at low, then you can't give a strong recommendation according to grade, and you can only give a conditional recommendation. If your strength of evidence is either moderate or higher, if the group decides, you can give a strong recommendation. So that's something that I think it's important when you're looking at the recommendations and trying to understand like the choice between strong and conditional. If the evidence strength is not high, then you are limited in terms of the type of recommendations you can give. So just a couple things. For open surgeries, we looked at cardiothoracic surgeries, we looked at open abdominal and retroperitoneal surgeries, then we were able to give strong recommendations because the level of evidence was moderate or higher. So for cardiothoracic surgeries, we recommend fascial plane blocks. And this is based on RCTs that were published from 2013 to the end of 2024. And that was based on the reduction in terms of pain scores and opioid requirements. For open abdominal, retroperitoneal, and pelvic surgeries, and we similarly were able to give a strong recommendation because the strength of evidence was moderate or greater. And we recommend fascial plane blocks to reduce pain and opioid requirements. And similarly, fascial plane blocks had been studied in terms of patient satisfaction. So we provided that information as well. We've already received some important comments and questions about the guideline. And why are we calling out fascial plane blocks, for example? It's not to say that these are now the gold standard, because I know that I work in a center where we still practice a lot of thoracic epidural analgesia. And I think that's really important. It's important to call out that thoracic epidural analgesia for open chest surgery and open abdominal surgery, I think we would generally agree, still is a very powerful and very useful analgesic technique. But when you look at the study range that we included RCTs, 2013 to the end of 2024, there aren't RCTs being performed in thoracic epidural analgesia. There are a lot of RCTs being performed in fascial plane blocks, which is why our systematic review and meta-analysis included and incorporated the data from many of those studies. But I think that's important. I mean, we also have recommendations for mastectomy, for minimally invasive surgeries, cardiothoracic as well as abdominal, and we have recommendations that we include for pediatrics as well.
So the regional anesthesia techniques called out in certain instances, saying some of the feedback you received was that individuals felt that they were more valuable than the studies were showing, or that there was a lack of evidence to show that.
Yeah, and it's important to have in many of these academic discussions when it comes to guidelines, because as I mentioned, how they are created, I think is very, very relevant. But when we consider limiting the timeframes for when we do our literature searches and incorporate evidence, we want to make sure that the guideline is as relevant as possible for the current practice. And I do think that the predominance of fascial plane block studies that we've seen in the last 10 to 15 years, it does reflect in many ways the modern regional anesthesia practice, as well as some of our surgical partners' emphases on enhanced recovery. And yeah, we've seen the surgical techniques change, and with that, a rise of minimally invasive surgery. We've seen the time frame for recovery from those surgeries, even though sometimes the surgical time itself is a bit longer, the time in the hospital is a lot less. And so, in being able to target certain parts of the body with these regional techniques that where we inject local anesthetics into fascial planes, it does serve an important purpose and also avoids the motor block and even some of the sympathectomy causing blood pressure fluctuations that may not be in alignment with some of these enhanced recovery priorities. But I mean, it's a great discussion to have. And I know when we presented this as actually a late breaking session at the ASA annual meeting in the fall. And so we got some really great questions. And as you can imagine, it's not just from the regional anesthesia enthusiasts, it's from our colleagues and friends who are practicing general anesthesiologists. And they want to know, well, am I still doing the right thing for my patients? And I think it comes from a good place. Does it still make sense for me to be offering thoracic epidural analgesia when I work in a major cancer center? I said, absolutely yes. If you're in a specialty center where you're doing major open surgery every single day, and not only are you providing a great analgesic service for your patients for that type of surgery, but you're also probably working in a center where you use those techniques so frequently that you maintain not just your skill set, but your success rates. And you have systems that can accommodate in that type of high volume epidural practice. It's just when you look at systematic reviews and meta-analyses, as I mentioned, you have to have a time frame for when you include studies. And we just didn't see a lot of epidural randomized clinical trials since 2013, when our last practice guideline was published.
So from what I understand, the guidelines, they're being released in two parts. The first part being about regional anesthesia used for truncal surgeries. And then there's going to be a second piece coming out related to limb and spine surgeries that I believe is next year, if I have that right. Is that correct?
Yeah, you're absolutely right. And it has a lot to do with this process. And we're very fortunate. I mean, I think we have a fantastic team at ASA in terms of practice guidelines and parameters, and our manager, Stacey Hewell, and then our practice parameters chair, Dr. Karen Domino, and our methodologists. And they're just an incredible team. And that systematic review and meta-analysis process not only goes through what you would expect, like as a researcher, like an academic, going through the research steps, but then also gets submitted to our board of directors at ASA, and then has to be voted on by the House of Delegates. And so we're already underway with the second part, which is going to be focused on musculoskeletal surgery. And we'll be presenting the preliminary statements at the upcoming March board of directors meeting.
And the two parts, was it the logistics that made it easier to digest into two parts?
Yeah, I mean, I think first, if I go back, I'd say it does make sense. What we've seen, at least in terms of perioperative pain management, just as an area of subspecialty, it has really been moving to a procedure-specific evidence and procedure-specific recommendations for some time. And I think that's a good thing. I think that's a reflection of the fact that even though we know individuals can also be different, then we also recognize that surgeries themselves can generate not just a different level of pain after surgery, but also have a very different recovery trajectory after surgery. And it does make sense for us to try to craft recommendations around procedures whenever possible. And so that was definitely part of it. I think the body of information and the number and volume of different types of surgeries is also another reason. We're fortunate, as I mentioned, to have just an incredible ASA team. But even looking at the scope of work, it did make sense to try to divide them. And they naturally broke down, as I mentioned, this first one, where we really focused on more truncal surgeries or intracavitary surgeries. So intrathoracic surgery, intra-abdominal, intrapelvic surgeries. And that also tend to align fairly well with the literature that we saw, because the emergence of fascial plane blocks in the last 15 years has really mainly focused on chest wall and abdominal wall types of procedures. So those aligned really well. And then the second part that we're currently working on, the musculoskeletal, is another area where there's been a fair amount of study and a lot of even specific guideline on certain types of orthopedic surgeries like arthroplasty of the lower extremity as well as shoulder surgery. And we definitely recognize that there's a clustering of evidence in the literature that tends to allow that type of division. So these two parts, I think, are incredibly complementary. Neither one really tries to focus too much on the multimodal aspect because ASA has already led the way in that work with the pain summits, but it's really to focus on the additional or incremental value of adding regional blocks to multimodal analgesia, which is why I think the two parts really work independently as well as complement each other in the evidence base.
Okay, sure. Well, you've mentioned the rigorous process that the guidelines have to go through, and you already alluded to a couple steps that the guidelines have to take within the society before approval. It's such an important point because I think a lot of anesthesiologists may not be as familiar with this process, or it's a vague process to them. Talk just a little bit about the process again and why it's so important that there is a rigorous process, and relate it maybe a little bit to a guideline versus a standard and how that might look.
Right. ASA is really looked to, not just in the US, but really around the world for the academic rigor that goes into standards and guidelines. And I think it's really important to point out when we talk about standards and the reason why it's so critical that we use the right nomenclature and we don't mix up, even in conversation sometimes, the word standard versus what is a guideline or recommendation is because a standard is something that you must do. And it's very important. We've seen recently, just talking about patient safety, ASA has very few standards, and they're always at the very top. When you look at ASA's page that's dedicated to standards, guidelines, and statements, standards are always first. And that, I think, is looked to, especially within the US, as a medical legal benchmark, as well as a very important a standard document that hospitals and practices can use, especially when they are looking to establish anesthesia services or perioperative services. So if you look at guidelines, guidelines are really the next level down. They're incredibly rigorous. As I mentioned, just the process that we use now is even more rigorous than we used to use at the time when we did our first guideline. And the way that ASA approaches a guideline, it is a clinical practice guideline. It's something that is being issued by the society with the strength and evidence behind it to recommend, hopefully improvements in practice that will improve patient outcomes as well as improve patient safety. That's really key because the guideline has to be an aggregation and summation of the evidence. And so that's why when we go through and we do a systematic review, we try to evaluate the highest level of evidence using grade. We limited ourselves to using randomized clinical trials because the systematic review and meta-analysis of RCTs is still top of the evidence pyramid. So we try to base our recommendations based on that. And then what goes along with using grade criteria is that if the strength of evidence is not high enough, is not moderate or higher, and then we're limited in how much weight we can put behind the recommendation. It doesn't mean that it's not a recommendation. So, for example, when you see, say, minimally invasive surgeries, cardiothoracic surgeries is one in this current guideline, it has the conditional recommendation, and it's worded in the way that is allowable with a conditional recommendation. So that is worded very thoughtfully as we suggest regional techniques, including neuraxial and fascial plane blocks to reduce pain in the first 24 hours. It's because the RCTs that were included in that surgical population, minimally invasive cardiothoracic surgeries, they only met a low level of evidence. And so we're forced to do a conditional recommendation rather than strong. It doesn't mean that we don't recommend it. It just shows that our recommendation has to be put in the context of the evidence. And that, I think, it adds credence, it adds confidence in the ASA guideline process, as well as the guidelines document itself. Because as I'd mentioned before, these guidelines, they do live in a certain time frame, and they're based on studies that come out in a certain interval. And as evidence evolves, if all of a sudden we're seeing a lot more RCTs, very well-conducted blinded RCTs in this area, then the next time we look at the evidence, our level of evidence and our guidelines, our recommendations may change.
So how can listeners who are listening to this currently educate themselves more fully? Or are there opportunities or resources that you would point them to?
Well, yeah, this is one thing that we've been really trying hard to improve within ASA, and I think we've seen that with our recent guidelines. When you look at the guidelines for the care of the older adult, and we look at guidelines for neuromuscular blockade, and we've tried to tie those into an educational program. So we're going to be doing the same thing for these guidelines. We have two parts. So the Truncal guideline is already out, and that covers cardiothoracic surgeries, abdominal pelvic, as well as mastectomy. And then we'll have this second part that is going to start this process of going through our board and House of Delegates, and then we're going to be looking at at a publication targeting somewhere within the next 12 months. Yeah, but the educational program is going to launch most likely somewhere in the middle of this year. And we're going to have educational resources that will be available. We're going to be putting together some programming. We're in the process right now of setting up different types of modalities for learning, some of which will be similar to this, where we'll be talking a bit and providing some audio only, as well as some online webinars. We'll also be doing some interactive sessions and trying to find some slots in the live meetings. But I think that's going to be available very soon. We want to make sure that all of our listeners, members and non-members, are going to have access to this information, so that way they can best utilize these practice guidelines.
Wonderful. Well, before I let you go, talk a little bit about where you see the treatment of pain going in the coming years. It's changed so rapidly already. Are you optimistic about it? Are there things you're concerned about? And just what's your general sense going forward?
I think I'm very optimistic. Yeah, right now is an interesting time in that we are really at the intersection of hands-on, high-touch clinical medicine, as well as artificial intelligence and the incorporation of technology in medicine and pain management. And I do think that there are ways that we can combine the two. And I think that our interest in perioperative pain management and just how it affects the overall recovery for patients having surgery really shows the value of anesthesiologists and the importance of our leadership in this area of perioperative analgesia. And I do think that it has potential long-term implications, because if we could treat pain well around surgery, we can decrease the severity of pain after these major operations. Then we know that that's one of the risk factors we can target that can potentially reduce the incidence of chronic pain. And that's a public health problem. So I think it is exciting. We have a lot of work to do in the research space to try to best identify patients who are at risk, because right now, we can't quite get so personalized in terms of our pain management yet. But we can be procedure specific today, which I think is a big advance. And one day we'll add that procedure specificity to that individualized pain management. And I think we'll be able to really make a huge difference for patients.
Excellent. Well, Dr. Mariano, I can't thank you enough for joining us on this episode. Thank you so much for sharing your expertise. And I would love to keep talking about these topics and even delving into some more specifics. So we'll definitely have to have you back on another episode where we can get into some more details on some of these things. But thank you so much for joining us.
Well, I'd love to be back. Well, thank you so much, Adam. And thank you so much for really just providing this platform, and also allowing so many of our members, our listeners, to really learn and get insights into a lot of the things that ASA is doing.
Thank you. And to our listeners, thank you for tuning into this episode. If you want to know more about the guidelines that Dr. Mariano has been talking about, you can always start by going to the ASA website, www.asahq.org/pain guideline, all one word, pain guideline. And please tune in again to our next episode of Central Line. Take care.
Hello, ASA. I'm Dr. Patrick Guillaume, your ASA president, and this is the Monday Morning Minute. First, recent communications from South American societies describe healthy patients who suffered catastrophic injury and death after routine general anesthesia. I encourage you to review the guidance issued by ASA and SPA. Next, ASA's Advance meeting in Vegas had record-breaking attendance and outstanding keynote presentations on communications and resilience. And last, the Joint Commission updated its accreditation manual for acute care hospitals regarding who may administer anesthesia. removing student nurse anesthetists. Anesthesia groups may wish to review and consider amending their policies and procedures. Well, that's it for now. I hope you'll follow us on your favorite social media channels and check out my weekly Monday morning outreach.
For more detailed and timely information, don't miss Dr. Guillaume's Monday morning outreach email delivered exclusively to ASA members' inboxes every Monday at 5 a.m. Eastern. ASA's Monitoring and Antagonism of Neuromuscular Blockade Guideline offers practical, evidence-backed strategies for quantitative monitoring, TOF assessment, and safe pharmacologic reversal. Use these resources to enhance airway safety and support faster, more reliable patient recovery. Access the guideline at asahq.org/blockade. Subscribe to Central Line today, wherever you get your podcasts, or visit asahq.org/podcasts for more.